Check 1 2. All right. Good morning, everyone. We're going to get started. Welcome to the Human Services and Government Oversight Committee's joint informational hearing. Just want to start by thanking the families who came to meet with many of us about their experiences with abuse and neglect of their adult children. It's because of your advocacy and your determination that we were able to pass legislation last year that requires a report that we then got issued the first report in February. And it was telling, it was startling, it was disturbing. There's more than 4,000 reports in 1 year and 15 deaths. I also, though, want to start by saying we respect and appreciate the work of the Department of Developmental Services. And so everyone here today wants to ensure that folks with intellectual and developmental disabilities get the best care possible. And so it's from that lens that we are having this informational hearing so that we can work together as a team to improve conditions here in this state. With that, I will turn it over to my good chair, Senator Leston.
Thank you, Madam Chair, and thank you to the folks testifying before us today. On this committee, we are not afraid of asking tough questions. And for too long, I think people were not asking questions about the care of people with disabilities in the state. And we know that we believe that every single person in this state is entitled to dignity, to bodily autonomy, and to safety. And so appreciate having the opportunity to ask these tough questions, to take a look at folks in the care of DDS and make sure that we're doing the very best. We also want to make sure that we're giving the agency and other agencies the tools to make sure that everyone in this state is safe. And we have some questions, and then we'll find out more and go from there. I can't think of anything more important for this committee to be looking at, and I'm so grateful to have the commissioner in front of us this morning to ask some questions and see if we can get a little bit more insight into what happened in these cases. And with that, I'll turn it back over to you, Madam Chair.
Great, thank you. And now I'd like to turn it over to our Commissioner of the Department of Developmental Services, Jordan Sheff.
Good morning. Representative Gilchrist, Senator Lesser, Representative Comey, and Kite. I appreciate the opportunity to discuss that report with you. And before I proceed, I'm joined by my colleagues to my left, Katie Rock Burns, my Chief Operating Officer, and Elisa Villardo, my Deputy Commissioner. Later this morning, I'll be joined by other colleagues to talk about the report that don't work for the department. Sarah Egan, who I've had the pleasure of working with for 10 years in a couple of different roles now, and Tom Kosker, a representative from Disability Rights Connecticut, who we have worked with on a number of projects since his hiring there and continue to work with both of them. I want to just speak a little bit to the report. You have it in front of you. It is, I have learned over 10 years not to know exactly, not to expect every question that you may ask. And so rather than prepare for any potential question, we're ready to get into the conversation portion of this shortly so I can address the specific concerns you may wish to raise. I'd also like to acknowledge the families and other advocates that are in the room today. None of the folks over my right shoulder are strangers to me per se. And we have worked together over their concerns. And I'll share from a personal perspective that this work is really important to me. A couple of the folks who are in the room today are aware that my daughter has a disability. While not under the purview of the department here, and in fact not living in Connecticut, while living here, was a victim of abuse and neglect in other systems. So being able to report and improve systems is important to me, both at a professional and personal level. And my experiences with Stella gave me a different set of eyes and a different empathy than I might have otherwise had. Though I've been doing this for 37 years, and preventing abuse and neglect has been paramount for me in all of my roles, both in the private and public sector. Representative Gilchrist, you used two different words in opening your remarks, and I want to share that, of course, these types of reports are concerning. I share that sentiment. I think that I'm less startled, but that's partly because I have some insight into how we got to the report that's before you today. There are several factors contributing to a growth in those numbers, and those numbers alone may not be startling, may be startling, but in comparison to some of the other numbers you report. There are a couple factors that drive that number higher from our perspective. One is the reopening of COVID, that the years of data prior to that were years where individuals were home, either in their group homes, their apartments, less going out, less eyes on, less exposure. I think I was startled by the decrease in abuse and neglect reports during COVID more than I was the increase coming out of COVID. Two other factors drive that number higher today than it might have previously been. One is our ongoing work with the Office of the Inspector General under the Health and Human Services Cabinet at the federal level. We have worked closely with them to improve our systems. That has included recommendations from them on training, as well as recommendations from them on how to use some electronic systems that we developed that they love to better detect things. So those two, that ongoing work with them created two outcomes. One, we did a lot more training. I believe and am pleased to see higher numbers in reporting of abuse and neglect. It means I have more eyes and ears from people who've been trained to see something and say something. And I think it's important to note that that's an outcome of training. Things that might not have otherwise been perceived as potential abuse and neglect are better perceived as potentially being that. And the understanding of the mandated reporting rules that require all the eyes and ears involved in our system, from direct care through executive management, through our hospital systems, through our emergency management systems, through our medical systems, have raised the expectation for people who are mandated reporters to in fact report things. That has increased our workload and increased the number of reports. The substantiation rate you see is lower. I would much rather be in a situation where we are over reporting and under substantiating than the other way around. So in that way, I think that Representative Gilchrist, I am less startled by the data, yet still concerned. I also want to share the ongoing work that we've done with regards to the other factor that drives up reporting. About 10, 12, well, it's longer ago than that. I've worked for the state for about 12 or 13 plus years. Prior to that, there was a Hartford Current article talking about abuse and neglect. Senator Murphy requested the involvement of the Health and Human Services Cabinet and the Office of the Inspector General to look into abuse and neglect in our system. And we began a relationship with OIG about the time, just before I walked in the door to state service. We've maintained that relationship, and we have partnered with the Office of the Inspector General to improve things. We could have simply responded with a spreadsheet and some data and some talking points and probably satisfied all their outcomes, but I don't think that that would have made the types of improvements to the system that we've been able to make otherwise. What we have done, and has now been replicated across the country based on the work that Connecticut has done in partnership with a company called PulseLight, using a platform they refer to as Aura, harnesses the data in the Medicaid, Medicare information system, the MMIS system. For many years, we have had a ton of data points in there that we had not leveraged, that we couldn't see. Through an opportunity to partner with the state Medicaid agency, DSS, we have utilized that company. They ingest data, not just from the MMIS system, but from multiple systems, so that we can actually use the data that we collect instead of just warehousing it to do a number of things. I'm going to focus today on the way we use it to address abuse and neglect in our system. So what they are able to do for us, and what we do as a result of our investment of time and talent with them, is we look at Medicaid claims data for types of injuries, types of treatments, frequency of visits to different places in the Medicaid system. And we use that to identify situations where there may be potential abuse and neglect. Uh, there's a process for this, and I won't get into the granular detail of all of that unless you have specific questions on that. But where we use that data to look back at our system and see if critical incidents were reported, if abuse and neglect was reported, and where it's not, we use that data to start. We reach out to the provider, whether it's public or private, and ask, was there an incident report related to this that was created? Was it triaged for abuse and neglect? And if it wasn't, should it have been? And that has also led to an increase in more reporting. I think that's a good thing. Those are things that have gone undetected for years in the state that we can now detect, that other states now detect as a result of the time we put in there. And instead of a simple response that would have satisfied the OIG, we've continued to work with them. So when they came back on their most recent tour, while they were focused on certain specific issues, they took the time to work with us to say, hey, as we've looked at this state, we learned that this might be an indicator. When we've looked at this state, these are data points that we missed, and we reincorporate that into what we do and continually improve the work we do with that product. So we sit before you today, we share your concern. We would love a system that had no abuse and neglect. I'd be fearful of a system that didn't report abuse and neglect, because I know that despite good intentions, there are adverse outcomes for individuals in our system that none of us like and none of us would want. I think there's other information I wish to share today, but I think that will come up in conversation that we discuss later. Before I yield back to you, Representative Gilchrist, I'll simply add, abuse and neglect is not a good thing. And I won't reflect specifically on the abuse, but the neglect portion of this. Neglect is a very broad term in our system. So when you see reports of neglect, some of them are indeed the kinds of horrific things that terrify all of us at night about what may go on in an institutional system in this state that serves on a daily basis 13 or 14,000 people across the state. Some of the neglect is still really important, but does not reach that level of adverse outcome. Neglect can be defined, the way neglect is defined, and we take a broad interpretation of it. Some of those are systemic neglect issues, failures to follow supervision guidelines, medical reporting that's gone undetected, a failure to pass meds, lapses in licensing, where there's no adverse outcome, but we still find neglect because those things should have been in place. No, there was no adverse outcome for the individual, but we still find either agency neglect or specific neglect on specific staff within the system. We take that very seriously, and in fact use the abuse and neglect registry at the back end of that to prevent specific individuals from continuing to work in the field here at in the services that DDS provides, but through legislation over the last couple of years have been able to share that registry with sister agencies to prevent individuals who might have been perpetrators of abuse and neglect here at DDS from working in other state systems and other private systems. I hope that we have a robust conversation today, and I want to say that in addition to the improvements we made based on findings from the Office of Inspector General. As I stated, we have shared data and been an open book to our partners who you'll hear from later. And we sit with them at tables, multiple tables for various reasons to talk about systemic improvements, and in fact have included and implemented recommendations they've made to some extent. I don't think that Tom and Sarah and I disagree on the facts. I think sometimes what we disagree on is where to focus our energies on incremental change to improve the system to move forward, and what we can do and the feasibility of what can be done within our appropriation and within the limits of my purview. So with that, I thank you again for the opportunity to be here, and happy to answer any questions. I will defer to my colleagues, probably a little more than you're used to, because they have sat specifically at those tables I just mentioned. Katie in particular with Sarah on both adult and children issues, and Lisa with our partners at Disability Rights Connecticut.
Great. Thank you so much. And I know I have a bunch of questions. I'm sure others do too. So I'll make sure we go back and forth, but kind of just ground setting, the report itself. when we're talking about the allegations of 4,246, is that 4,246 individuals or 4,246 instances? And so it could be an instance on multiple instances on the same person.
Yes, it could be, it could be multiple incidents with the same person. It could
Okay.
also be a single incident that impacts 5 different people. And so, for instance, one of those neglect issues that I talked about, um, uh, that occurs, particularly some of the things that happened upon reopening during what was a tremendous staffing crisis, remains a tremendous staffing crisis, though somewhat improved post-COVID. A residential program is required through by the individual plans and by our oversight to have 4 staff on a vehicle when they transport to the day program. When the day program greets them at the day program and realizes there are only 3 staff, they report to their supervisor there was not appropriate staffing on the van. If there were 6 people on the van, that would be 6 neglect reports for the not having one staff, and there may have been no adverse outcome. If a nurse or a staff had a lapse in some credentialing for passing meds or for a DPH license or something, and they were overseeing 20 people in the system, that would be 20 neglect reports for failure to have that paperwork. Right, there would be 20 potential victims, so that would be 20 different incidences of neglect. I've got them. I'm getting affirmative nods to my left. I should have put them up there to support me in that way. So I'll keep looking to my left to make sure. The book of business we have is so large. I cannot be the level of expert at granular detail I would love to be in all these areas. So I'll keep deferring to them to confirm. I'm not making stuff up as I go. But so that 4,000 plus number may include incidences where there was a single perpetrator and multiple victims or potential victims of that neglect or abuse.
Okay, thank you. And then do these numbers include investigations by DCF, the Department of Aging and Public Health for individuals in those age groups and programs, or no?
These refer to allegations made to our DOI, AID, Department of Investigations, and our Abuse and Neglect Division. Sometimes what may open as a DCF concern takes place at a licensed group home, and that may be reported at both. So DCF may get an initial intake. They may then call it into us. So you may see a data point on the DCF side that we share, but how that's shared and where that Venn diagram, how that looks, is not illustrated in the data that's been provided to you and would be particularly difficult to pull.
Thank you. And then, like I said, many questions, but this will be my final and I'll turn it over and then I'll come back. I was surprised, here's all my different words, surprised in looking at on page 7 of the report, the investigations that the overwhelming bulk are done by provider only. So can you dive a little deeper into these various categories in table 3, what that looks like, what that means, and why I am so surprised because my take as a layman reading this is, wow, the providers who are being accused of abuse and neglect, the very entity that's then investigating their staff who potentially did the abuse and neglect seems problematic, but I don't know.
Sure. So I understand the concern, the surprise in that. It's consistent with a lot of other industries. When a plane crashes, the airline typically begins an investigation and the FAA decides whether they'll assert authority over the investigation or not. Certainly the airline is through the process reporting to FAA their findings. In other instances, when there's an incident in a police department, there's an internal bureau that investigates that internally. Another office may assert authority and take on that responsibility. So I don't think that industries allowing entities to do self-investigation should be surprising, considering it's the way most of our oversight works throughout government and throughout private and public interests. I will also share that none of the investigations are done without oversight from the department. And I want to know that the oversight is very close. The private providers begin an investigation. They make us aware. We assign an investigator who then partners with that agency specified investigator to go through that investigation with multiple checkpoints and often pushback from our state staff to providers. Why didn't you investigate this person? Did you ask these questions? You still need to ask that question. Sometimes we find the recommendations or findings from providers fall short from our expectations. It's one of the reasons our timelines, which is another area that I'm sure we'll get into later when we're talking with our colleagues, why our timelines get pushed back, because a thorough and proper investigation is more important to me than a timely investigation is to me. We also often involve with providers, there's police involvement, and police, because the level of abuse or neglect reaches a level of criminality that the police are involved. It's another reason sometimes investigations take a lot longer, because we stop our process while the police do their process. The fear being that anything we may do could contribute to a potential charge not happening because we've somehow interfered accidentally, incidentally with a police investigation. But I'm going to ask Katie to walk you through the table, the specifics of what you see before you and what those terms mean and how that plays out in front of you, so you can understand that table a little better.
Sure. Thanks, Commissioner. Good morning. Yeah, the Commissioner covered most of that, but I think the other important thing to note is that any investigators who are investigating on behalf of the providers do have to be certified through a training that our Department of Investigation offers. So we keep a list of who's certified. The investigation needs to be completed by one of those individuals. They could work for a provider. They could be a third party that the provider contracts with, but either way, they have to have gone through our specific training. They have to be on our certified list. And then, as the Commissioner noted, our Department of Investigation reviews all investigations, whether they're done internally or by a provider investigator, signs off on them. The regional staff also need to sign off on them before they're considered final. So there are a lot of layers of oversight on the process, even when a provider is leading on the investigation. So the categories noted are DDS only would be our DOI staff conducting the investigation. Provider only would be a provider investigator, and then other only, it covers those external entities, primarily police that the Commissioner referred to. And as he noted, we will pause our investigation to defer to them until they're done. So I think that covers the three categories.
Thank you, Katie. The only other thing I'd add is a number of our investigators are retired police and detectives. So the state employees that are overseeing these work in teams. While they may have specific assignments, there are retired police and detectives available to them within those units to talk about investigations, what should be asked, what shouldn't be asked, and to look at that. So there's a fair level, more than a fair level of oversight. And while those two departments, AID and DOI, are under my purview, I can assure you they maintain their autonomy and their willingness to push back on the Commissioner when we are talking about investigations and outcomes, particularly the division leader, Kendra Lally, as well as many of the investigators who are police will let me know that they think this should be the outcome, and they will bring that those concerns to other places if they think that I'm not in agreement or in alignment with where they think they're going. We'll have difficult conversations about some of these things. Similar to our ombudsperson, who you know, we work alongside each other, but I have a lot of staff unafraid to hold my feet to the fire, so to speak. Their allegiance is to fair outcomes for people we support and not to me.
Thank you. And then just, so what would be like DDS and provider? What would that look like?
So that would be, some of our cases are large enough, complicated enough, egregious enough that we want to work alongside the provider right from the outset. So we may assign an investigator to work jointly with the provider, and then the entire investigation, including fact finding and statements and all of that, is done jointly.
Thank you. And then other only?
So that would be the category that like police investigation would fall into, things like that.
Great. Thank you. Senator Lesser?
Yes. Thank you, Madam Chair, and thank you, Commissioner. You know, this is um, such a dispiriting report in just the scale of the issues. But I want to talk about something that my co-chair just touched on, which is the issue of self-investigation. And I understand you're defending the system, and I just want to understand what DDS's um, protocol is to ensure that there are adequate safeguards to prevent conflicts of interest and ensure independent, objective findings. To me, it seems that in many cases, the folks conducting the investigation might have a vested interest or a potential conflict of interest that we need to manage and understand.
Thank you, Senator Lesser. I get that appearance. I don't think our providers are in the business because they're mission driven. They are here because they believe in the commitment of what we do and the value of individuals with intellectual disability. I don't think they're in the business of trying to cover things up. I think if we begin with the premise that providers can't be trusted to do investigations, then we have to ask the question, should providers be trusted to provide care? Because it's the same thing. It's the inherent charge for them is to ensure health and safety and positive outcomes for people. So I think we do need to be part of a system where providers can be trusted to a degree to do that. Where we have concerns, providers who have a history of lots of reporting, we may assert ourselves and insert ourselves into that investigation process earlier. A provider who's transitioning leadership, we may be an opportunity where we say, listen, you're new and on shaky ground. We're going to insert ourselves either directly or in partnership with you. We have providers who are part of a system we call enhanced contract monitoring. We have our licensing and our eyes on them have suggested that there are some failings in their system, and we may not wish for them to do that. In some of our larger providers, there's a mix. There's regions in the state where they're operating and performing well, and there's other areas, specific houses or specific programs where they're not performing as well, and we may insert ourselves there as well. So that determination as to who does the investigation is made by the department. Providers don't get to decide when they're going to do it instead of us. If we decide to insert ourselves, we may also direct them to hire a trained by us, but for lack of a better word, private investigation firm. And we fund them to pay that entity to do an investigation. They are independent of the agency itself, and they can hire an outside agency to do that. Providers are pretty good when they perceive conflict of interest in letting us know that they need help because they're not sure they can do it autonomously. And that process starts at the intake level with our Division of Investigations and AID teams, and they make that determination.
I appreciate that, Commissioner, but maybe I'm a little too cynical. But I'm aware of numerous recent incidents where there was litigation around clients' care and judgments in some cases in the many millions of dollars, potentially threatening the ability of a nonprofit to remain in place. So if you're I understand no one goes into the business of running a nonprofit to and contracting with the state to do harm. I don't think that's why people do this, but I just don't agree necessarily that that there isn't a conflict of interest that needs to be managed. And I'm one of the things that I'm mindful of is that we used to get fewer complaints. You're suggesting that the reason the number has skyrocketed, as I understood your testimony, was because of increased reporting. So we presumably had the same nonprofits a few years ago and they weren't reporting. So how do you square the lack of a conflict or a manageable conflict with the fact that we're getting far more complaints than we were a few years ago?
I'll point back to the fact that you're using data compared to an era during COVID where folks were at home, insulated, and a much lower availability of staff. There were a lot less eyes and ears, and there was a lot less crossover. people going out to day programs, going out to employers, going in person to their medical doctors instead of being remote with their medical doctors creates an opportunity for more eyes and ears. And I really do think that that increases reporting. We've also done extensive training at the recommendation of both partners in the room as well as the feds to improve the training so that people understand their mandated role. I think those drive the numbers up in addition to the work we're doing with Pulse Light Aura. That conflict of interest is one we've been talking about for a long time. I'm less familiar with lawsuits resulting in $1 million of payments. While there are a few in my tenure, one was before I was commissioner where we exacted that type of penalty from some egregious outcomes from a provider. The others are civil suits and not suits that I'm aware of. There are a couple that have been recently we have a couple of ongoing suits unrelated to abuse and neglect. So maybe later, if you have specifics about millions of dollars being paid to families whose loved ones were the victims of abuse and neglect, you could share some specific data with me. I'd like to hear more about that.
Okay, happy to have that conversation offline. So one question though, because you did talk about the pulse light data, my understanding is that that data doesn't currently include, at least according to your 2023 audit finding, in your response, you suggested that that did not include ED visits. It only included some data. Has that issue been fixed?
I don't know that it's not all hospitals participate in all of the systems that DSS has in place, and the use of, and I'm going to defer or ask Katie to correct me if I'm wrong here, but there are state systems like Connie, and there's another one about the emergency room visits that gives us better data. And those two, as I said, the company that we work with ingests data, and now I think they get that feed. I forget the name of the other. Oh, emergent, discharge transfer, emergency discharge transfer, I think are the initials for the EDT system. So we have harnessed additional data to make that improvement so that we can see not just hospital claims, but emergency room visits, and we can see it closer to real time. One of the reasons those things fall behind is the way hospitals and others bill Medicaid, because we don't see it till Medicaid gets claimed. As you are all keenly aware, the hospital systems feel that the Medicaid rates are insufficient. Very often they prioritize private insurance billing over Medicaid billing. And so there's a lag sometimes in how hospitals proceed with claiming, and we may not see that data for months, not because we're not looking for it, but because they haven't billed for it. So we don't see those billable codes until they actually bill for them, and that creates a delay. But though there have been those improvements. We have a business intelligence unit. We didn't when I started. We do now, and we have a data scientist who's pretty brilliant, who partners with our contracted company to continue to look at that. We are struggling, although we have eyes on also including Medicare data down the line. We don't have that. Medicare data is not readily available to us, but it's a conversation that Commissioner Barton Reeves and our legal teams have discussed how we can share that data as well. Pennsylvania may beat me to the punch, but both Pennsylvania and Connecticut have been working hard with their state Medicaid agencies to harness that. I think they may get to it before us.
So what mechanisms do you have in place to ensure that corrective actions required after substantiated abuse or neglect are actually implemented and verified within a defined time frame?
So when things don't go right at DDS, I'm at the top and I'll take responsibility. We are not doing as good a job as we could on follow up on corrective action. And I wish we were doing better, and we are working and have made some moves recently to do better as we pull this report together, identifying that that was an area of concern. Sarah, in her report, her written statement to you highlights that, and it's something that she highlighted in our conversations leading up to the report being generated. We had instituted some quality managers across the state, and this is not a failure on their part. They are very talented people. At the time, what we were asking them to do looked different because during COVID, our reporting numbers were different, our investigation numbers were different, and our follow-up outcomes were different. As those levels rose, we did not provide additional resources to do the follow-up in a timely manner. Further impacting that is providers' availability of staff to make some of those, make themselves available for us to continually visit and monitor those things. So we have work to do in that area. It's an area of concern for me and some active work we're doing. But that is not a reflection on my staff. That's a reflection on my inability to manage that the way I should have.
Do you have specific recommendations about ways that we can support the department in that?
I will get back to you on more specifics. The three quality managers we installed in the state, because we had not filled their plate during COVID with all of the responsibilities for follow-up, because there was less of it, we gave them additional responsibilities to fill their time. I now need to find a way to offload some of the work they were doing or provide them additional resources to do that follow-up. In addition to that, a number of years ago, there was a reclassification for what we call resource management staff. It now has a different name. What I call resource management staff, DAS has branded that a little differently. The way we used those staff 10 years ago kept them active and out in the field and doing those follow-ups. When we became a very remote workforce, their workload changed. The way they did their work changed, and we need to work to add additional resources and resource management to do that follow-up, to liaise with the quality managers in the state. And that's work that, again, I'm aware of, and that is ahead of us. And we've made some small steps in that direction currently, but it is not affecting yet the data that you're looking at.
So in table 4 of your report, you indicate that 27% of incidents were not substantiated. What does that mean exactly? Did the injury occurred from a clearly identifiable cause that was not abuse or neglect? Does it mean that the cause was not identified? Is it that cameras were not available, so we just don't know? Like, what does that mean exactly?
Thank you, Senator Lesser. One of my family members over my shoulder, she and I have been having this conversation for a long time. And I understand your question, and I understand some of my family's concerns around our use of the words not substantiated. When we say not substantiated, we are not able to attribute that injury and the cause of that injury being the result of staff committing abuse or neglect. It doesn't mean that the bruise didn't exist, or that the injury didn't exist, or that there was an adverse outcome for the individual didn't exist. That's not what not substantiated mean. What that means is that our staff, by statute, do not feel that the evidence rose to the level where we could interpret the injury as being attributable to a specific staff person or a specific agency flaw. So that's what not substantiated means. We have pictures of individuals with injuries that look like handprints, but we don't have any way to verify who may have caused those fingerprints on someone's bicep, leg, hand, arm. There's no way to always be able to detect that. In some instances, that's because the individual can't verbalize that, or doesn't have the capacity to identify a specific individual. So that's what not substantiated means, and it's a painful outcome for a lot of our families because they can see the injury and they know that it shouldn't have happened, and yet we can't attribute it and make it known who that individual may have caused the injury actually was. We may not ever learn that through the process of investigation.
So DSS as the single state Medicaid agency and the lead for the HCBS waiver has a federal responsibility to comply with federal law. And in so doing, as I understand it, it has oversight responsibilities over DDS. Can you talk about what oversight role DSS has and how a DDS, reports back on allegations of abuse and neglect to
Hold on, the state can what? Hello?
Hi, Representative Santiago, you're unmuted. Were you? Good to hear from you, though.
That was a little distracting. Can you reframe that question for me one more time? Senator Lesser just was out of
Yeah. So as you know,
oh, I'm sorry.
DSS administers the HCBS waiver and has a responsibility to ensure that federal law is applied is followed. And so I imagine it has an oversight role over DDS. And I was curious how that oversight role works in practice and with respect to compliance with HCBS rules.
So in practice, There are two ways in particular that we have partnered with them with their oversight. One is the use of that electronic system Aura and the harnessing the data in the Medicaid claim system. Their sharing of that and their work with the same agency, the same company, has been beneficial. They have, and I won't call out the specific staff because I'll get the name wrong probably. But as we've done the federal audits, we have liaised with them. They have eyes on our conversations. They have an introduction visit when the feds arrive, and then our Med Ops director, who many of you know, Krista, works specifically with the quality or audit unit. I'm not sure exactly what Commissioner Barton Reeves refers to that unit as. And then they are part of the conversations with the feds when we have that. They are also part of the assurance process through all of our waivers. The 3 waivers have assurances that we provide and data that we provide to that. That is funneled through our and reviewed by the state Medicaid agency in our process of working with the feds.
So key data such as corrective actions, licensing violations, and quality assurance findings are not consistently published by DDS. Will you commit right now to greater transparency in making those available?
I'll commit to having conversations about what that data can look like and how we might report additional data. I have some concerns I'd like to share with you briefly,
Please.
particularly since a number of my friends and families behind me are wearing pins about autism and the high levels of autism and what that means for our service system. That data could really skew the way the public perceives the performance of certain providers. As you're aware, there is a struggle within our system to place individuals with very challenging needs. Individuals with challenging needs often have higher rates of injury. Whether it's through abuse and neglect or not, it's often reported as potential abuse and neglect. Those agencies who have a willingness to work with those very challenging folks may become more reluctant if the data specific to their agency or a specific home is going to be publicly listed, because it will look like they're not doing a great job, when in fact they have a willingness to engage with challenging to work with individuals, as well as a high level of reporting, which we would want them to do. We want them to have a high level of reporting if they're working with challenging individuals. We would rather hear from them more rather than less. So I'm willing to talk about what transparency, what increased transparency can look like. We have tried to be as transparent as we can. I would want to ensure that we don't do things that would take away from our ability to utilize those agencies in particular willing to work with the most challenging individuals, individuals with co-occurring mental health issues, individuals with complex medical needs. When you have complex medical needs, there's a higher likelihood of reports of neglect, and with higher levels of autism and challenging behavior. So yes, I'm willing to commit to increased transparency. I'd like to talk about what that transparency could look like and how we could achieve that goal without detriment to the agencies that are really working for us to take on the needs of those challenging individuals.
Okay. I've been told I've gone on. Well, I know that there are other folks who have questions, and I don't want to hog the mic. I will just say, 15 people died in DDS care last year with abuse and neglect allegations. I'm looking at the table, 61 allegations of sexual abuse, 446 of physical abuse, 256 of financial, 193 of psychological. I mean, the numbers are pretty stark. And while I understand that we need to protect providers and we want to make sure that people aren't, with those needs, aren't afraid of the providers, there may be reasons for fear. And so I think we need to acknowledge that there's a problem and that there's a problem that we need to get our handle on. And if you ask me what side do we want to err on, more transparency or less, it's really hard for me to say we should hide these incidents from families who are just trying to do right by their family members.
I thank you for that, Senator Lesser. We want to make the system better. It's my challenge every day is to try and make that system better. I would like specifically, since you raised the issue of the deaths, to ask Katie to talk a little bit about the way that data is reported to you, and we can get into the other subsets a little later.
Thanks, Commissioner. Yeah, just wanted to take an opportunity to shed a little bit of light on that particular data point. So There are often unexpected deaths that happen in our system. Out of an abundance of caution and an appropriate level of oversight, those deaths are reported through our abuse neglect system just to take a look at what happened and make sure that there was no causal relationship. Of those 15 deaths, we wanted to provide a little bit of background information on them. 10 were substantiated for neglect or programmatic neglect. None were substantiated for any type of abuse. There were no types of causal relationships drawn, and none of the 15 were referred for criminal investigation by police. So there were a number of different outcomes and recommendations. They varied by case. Some of them did recommend separating substantiated staff. Often it was on retraining staff on various programmatic elements, ensuring that staff follow policies and procedures, and then also some documentation requirements. But just wanted to shed a little bit of light on the 15 deaths. None of them were indicated to have a causal relationship to any type of abuse or neglect that was substantiated in those cases.
And I would just like to add to that, the group that looks at those deaths is our mortality review board. The statute there requires me to sit on that board. I have chosen to designate my role there because that would be further the fox watching the hen house type of thing. My designee for that is a gentleman who's the former executive director of what's now Disability Rights Connecticut, was then OPA. He has no allegiance to me other than his willingness to do this for free and continue to hold my feet to the fire. And so those reports are looked at by a complex team of medical and program and providers as well as advocates. And I do believe I haven't overturned any decisions from them. I follow the recommendations as best I'm able. And while the statute reflects it should be me on that panel, I think we are best served by that being chaired by someone who is not the commissioner.
Thank you. I'll pass it back to you, Commissioner.
Great. Representative Dathan.
Thank you so much, Madam Chair, and thank you, Commissioner, for coming today. You know, to be honest, I was shocked that we had so many allegations there, over 4,000, with 43, almost half being substantiated. And a greater part of those are over neglect. And I saw the definition here in the report that you all use, and also your description that you provided earlier on in your testimony. I guess when I look at this definition, the failure by an employee through action or inaction to provide an individual who receives services or funding from the department with the services necessary to maintain such individuals' physical and mental health and safety. To be honest, that sounds like to me a training issue, that we have substantial issues within training of our providers. And I guess I'd like to understand from you if you think that that assumption is correct, or, you know, what we're doing to rectify that.
Thank you. I don't think it's incorrect, Representative Dathan. I think we should, I think more training is always better. Providers are strapped in part because of what they would articulate is funding issues, recruitment issues, retention issues, and the amount of time that their staff can spend being in a classroom setting receiving training versus being, for lack of a better word, on the floor at a day program or in a home in a residential setting. And we have those discussions with them. Providers in earnest across the board would prefer us to be able to fund them in a way that allowed them to do more training. A lot of that opportunity where they used to do more fell by the wayside during some of the more stark cuts during the Malloy Barnes administration. And when you had to, when we decreased rates, then we decreased a lot of what was available for them to indirect time. And despite the robust support from the legislature and Governor Lamont to increase their rates, that's been dedicated pretty exclusively to wages. What you continue to hear from providers articulating is a need for non-direct compensation so that they could go back to make some of the restore some of the things that were lost then, and we have not been able to get there. The last round of changes were not articulated specifically as a wage-specific opportunity, and some of those monies were available to the providers to make other indirect changes that they have wanted to make. I do think a lot of those are related to training. Although I do think a lot of the reporting that you see is because we have done more training. And I don't know if either of you have anything to add in the neglect space and how training might impact Katie or Lisa. Is there anything to add there? No. I hope that was responsive, Representative Dace, and I'm happy to dive.
Yeah,
further.
I mean, it's hard. I'm looking at parents here who are putting their children, adult children, in your care. And, when they put them in your care, they are expecting that their loved ones are being taken care of. And I just was kind of surprised at this whole thing. I think one of my other takeaways was, it doesn't sound like that this is, a couple bad actors. This is a systematic issue rather than isolated cases. I don't know if that's taking it a bit too far, but that's just my impression.
So I mentioned a data scientist that works for me earlier. She has cautioned me about, and I know your fiscal background and your familiarity with numbers. Um, uh, Regardless, she's asked me to be cautious about interpreting data at its surface level. I will tell you to sort of make that data point a little richer. There's some 25,000 plus direct care staff and others around the state providing care, 365 days a year, 24 hours a day. Given the number of touch points and the potential opportunities for neglect to happen, um, and the level of substantiation, right? So there are hundreds and hundreds and thousands of opportunities where adverse outcomes, where bad things could happen that don't. And so we need to focus on making improvements there. I would like that. I, I know this isn't popular in the room, but I'm really pleased to see the reporting go up. It means I have more eyes and ears helping me do my job. I'm pleased to see the substantiation rate go down. We usually operate at 50% and we're at 43%. It means we're over-reporting and under-substantiating. It's moving in the right direction. And again, the data for that year is post-COVID, coming out of COVID. There are systemic issues, and those are issues that we look to address, and we try and make improvements. The ability to look at the data, while we talked about it being used for for detecting unreported abuse and neglect within our system, we're also able now, instead of just using it to look back, to look forward. We can see through data the number of times someone might have been seen and treated for a fall, for a bruise, for a broken bone. And we can see that at a house level, at a regional level, and a client-specific level. We need to make improvements. We need better outcomes for people we support. I'm not here to argue that in any way, and we welcome your partnership in addressing those concerns, as well as the partnership with families and colleagues in the room. And we'll continue to commit to making the system better as best we can each and every day. That change will be incremental. We're talking about a very large system. It's $1.5 billion that the state spends, in excess of that every year on services for people with disabilities. It's not small and swift, and our best change is to make that incrementally and over a period of time. So we hope to continue to do that. And there's specific areas where we've demonstrated improvements on specific health issues historically.
I appreciate that. I also think that, bearing in mind, it looks like I calculated 70% of the times investigators are actually investigating themselves. So it seems to me there could be a conflict of interest there. And that was concerning. I think for me, I didn't see any direct consequences with the 15% of the cases where only 15% were actually had sort of consequences. But for me, it's like what's missing from this report is probably my biggest takeaway. I don't have any idea where we have repeat offenders, if there is, individual homes or individual personnel are actually to blame. I have no idea if recommendations that were made were actually followed. And then I'm thinking about family notification, and I know that's something that we've talked about in the Human Services Committee. And I think, this is a newer report that we have going here. And I think, as chair of the government oversight, I look at, ways that we can improve this sort of oversight and reporting. It just, we're talking about our most vulnerable population in our state and medically fragile in many, many circumstances. And I just have concerns that our investigations lack the sort of independence that needs to happen when we're doing these. I know staffing is a huge issue, but again, we need to make sure that we're doing what we can to bring these down, because I think that, training is a huge part of it. And I think that that's something that would be great to understand what sort of strategic plan you have for the agency to ensure that people that are vulnerable are being cared for by trained individuals. And I know there's other people with questions, but I
Thank-
just wanted to share that with you.
Thank you, Representative Dathan. Before we move to your colleagues, you raised one issue. I'm going to ask Katie to just, or Elisa to elaborate on, which is the way we use data to inform our quality system and our reviews with providers. Can either one of you take that?
Sure. Thanks, Commissioner. So the commissioner mentioned before that we had hired a handful of quality assurance directors, which we've installed in our 3 regions. It's actually after a lot of conversation with our colleague Sarah Egan over the years. And the idea behind those folks was to we have a lot of data points regarding quality oversight in our system. They live in their different silos. There are different folks in charge of those, from those specific lenses. But we didn't have anywhere where they could all funnel into and create a whole picture. And the best place to review that whole picture is with our providers who are providing all of our care. So first charge for those quality directors when we hired them a couple of years ago was to streamline what we review with providers at their annual quality meetings, take all those data points from all those different places, use our business intelligence unit to develop more readable reports and streamline that into a new way of looking at the whole picture of data points that we collect to provide a kind of whole picture of quality for any one provider. So they have been working hard on that with our business intelligence unit. They are actually just starting to socialize those new reports and new ways of kind of looking at the whole picture for a provider now. They'll be doing some trainings in the upcoming months, and we are launching, I believe, in the fall. So that's one of the major things that our quality directors have been working on to provide a more holistic picture of everything that's going on in the system, take all of the data points that we do collect and use them in a more holistic way. The other thing that we've invested in the last couple of years is WellSky, which is a new system that we will be implementing to house our data regarding abuse and neglect. Right now, it is an incredibly archaic system using access databases. So part of the problem with, as the commissioner was referring to, follow-up and corrective action is that we ask providers, we complete an investigation. There's a list of recommendations that we're asking providers to follow up on. And then the way that we track whether those things have been done is incredibly manual and therefore incredibly rife with missing data. So when we are getting ready to roll out WellSky, we will have better access to that as data instead of that as someone writing on a piece of paper and faxing it to our office. So we hope that that will also help us. I think a lot of times our corrective action is being completed. We just don't know about it because these systems are not allowing for us to capture that as data. So that's something that we're excited to be implementing this year as well.
Thank you. I appreciate that. And I do hope that we see some improvement when we talk about this next year. I think it's something that we probably need to have a continuing conversation on. And I look forward to that. So thank you, Madam Chair.
Thank you. Representative Fortier.
Thank you. And thank you for the report and your testimony. I'm going to ask a question about, again, something that's not in the report. In terms of recommendations, the types of recommendations for the particular allegations, we see that training is the big one, and we're not really surprised by that. But I'm wondering if there was anything that found lack of staffing as an issue. I mean, particularly when we see neglect as the biggest category of harm. Um, we hear about staffing issues generally in all of our providers in this committee. Um, and I'm just wondering if, the fact that there might not have been enough people scheduled at a particular time is what causes something to happen. Again, in the neglect category. And I mean, it isn't captured here, but I'm just wondering if you have anything.
That would be a little, we're getting better at managing data and pivoting data against each other. That would be difficult to sleuth out still for us, that's a specific root cause. But without question, the staffing crisis was about at its peak during this reporting period. It has stabilized a little bit. Most providers would say it's not getting worse, is the way they would qualify that. Not all of them would say that. Some of them would say it's still getting worse. Remembering that at that time, our department stores and our grocery stores were pushing starting wages well beyond what starting wages were in our industry.
Right.
And it is really important to me that food is available at my grocery store. I'm not diminishing the roles and responsibilities of making sure we all have food security by food actually being on shelves. It's important for them to get staff in to do that. Whether or not it's more important than the care we do and how we prioritize what gets funded is up to others and not up to me. Staff struggle with, if you were at ARC Family Day for the IDD caucus last week, you heard from staff at an agency in Manchester who has to piece together 2 and 3 jobs in order to work. So even when we are low staffed, she's there working 2 and 3 shifts a day. There has to be stress, there has to be fatigue, there has to be burnout. And I think that as the industry is well aware that those things do not improve your outcomes in this arena. They will only make your outcomes worse. When you don't have enough staff, when the staff you do have is tired and weary, it is more likely, particularly in the world of neglect, but also in abuse, that those things will happen. We have made a concerted effort to try and work with both the administration and the legislature to boost wages over the last 10 years, particularly in the last 5 or 6. And we have worked with the Governor's Workforce Council, with the Office of Workforce Strategies. We have dedicated an entire role at DDS from a former provider who worked largely in the west coast of Connecticut, where staffing can be particularly hard down in Lower Fairfield. Because of the cost of living down there, it's hard to have staff that live close to where services are provided. And she has been working with providers for a couple of years now, specifically on workforce issues, on retention issues. We also partner nationally with my national trade organization and the Association of State Developmental Disability Directors to look at workforce issues nationally as well as locally, and things we can do to make those improvements. So it's a long-winded answer to while the data, I can't show you data that would support your claim, I undoubtedly believe that is part of what contributes to this.
Thank you. Thank you.
Great, thank you. Representative Kitt.
Yes, thank you, Madam Chair, and thank you, Commissioner, for being here. You're obviously taking this very seriously and addressing these issues. I want to get back to the issue of the not substantiated cases. I want to clarify my understanding of the definition. So am I correct that not substantiating means there are signs that something may have happened, but you can't contribute it to a specific person or policy?
You got this one?
Thank you, Representative. I think that it can encompass a lot of things. So it can encompass situations like that where something undeniably happened, but there is no way for the investigator to determine the cause or determine who caused it if there's a who to be causing it. It can also be a circumstance where something was reported and people go looking and there's nothing to find. So I think it can be a lot of things. I think that what the commissioner was referring to with injuries of unknown origin and things not being substantiated because we can't find a perpetrator, that is not necessarily the majority of those not substantiated cases, though I do think that those are the situations that rise to mind for all of us when we look at that. But I think it can encompass a lot of different types of examples.
It would be interesting for me then, and I think important for all of us to know what that number actually is, the difference between unsubstantiated, meaning can't find anything happened, versus unattributable. Maybe that's a language difference we can somehow use in reporting, because there is a big difference and there are issues there that need to be addressed. So, for me, for over 1,000 cases of unsubstantiated, I would really like to know how many there were evidence of injury or neglect.
I, really want to thank you. The word unattributable. My friend Adrian and I have been having this conversation for a long time. And that word is helpful to me because the semantics are a struggle for us in the use of that word. And it's the accepted term that we've been using for so long. So I can't promise you today that we can insert a subcategory for that or parse apart the data the way we've collected it without physically going through the outcomes of each of the prior investigations. But we can potentially look to going forward, because I think that for families, that's an important distinction. We can agree that the injury occurred, but we can't attribute it to a specific cause, I think is what you're highlighting with the word unattributable. And I think that might be helpful to the long time conversation that my friend Adrian and I have had. So I would like to talk more about that internally first, so I can understand how much work I'm suggesting right now is going to fall upon my staff and how they might do that going forward. And I also need to look at the statutory language and the regulatory language as to how it's defined there. And we may look to you for assistance at passage of language that would broaden that, if in fact it's not just our own internal policy, but one set by all of you folks. So thank you for that word. It's really helpful to hear today.
Thank you. And I think that would help us formulate policies and programs to help prevent future cases of abuse and neglect, and make sure that we can address potential training issues. So thank you so much for taking that feedback.
Thank
You
you.
need to write it down, so no questions for a second.
They're taking notes for you, but I like what you're doing. It's going to be Rep Comey, but maybe give
Okay, I'm
him
ready now.
a beat. Okay.
Thank you, Madam Chair. Thank you, Commissioner. Thank you to your staff for coming before us today, and I look forward to the additional presentations we're going to hear. I was wondering, this is very, as we've already sort of summarized here, it's very high level data, and I'm wondering what are the different environments that, in other words, state-run homes, private group homes, community group homes, agencies running them. Do you distinguish between them in these reports? And I'm assuming this has nothing to do with, private, family homes. But I'm wondering if you distinguish between that, and if that is something that would be helpful to sort of track going forward, just to see if there's any trends or gaps in certain environments.
Thank you. So the data is inclusive of all of those environments, public, private, and family homes. Some of the allegations are made by providers against families and vice versa. That's a two-way street within our system that is at times really difficult to manage, because the services are essential and the relationship can become fractured. Not always, but sometimes. To frame what our world looks like a little bit, and I'm going to spit data off the top of my head. We do have a management information report that breaks down our service delivery. Better than 95%, or about 95% of our system is private and family-based, self-directed. Our footprint in public used to be very large. We now operate in the range of 35 or so public group homes, and 3 regional centers, and the remaining folks at Southbury. The large bulk of our system is providing services to people in private provider agencies, probably 85 to 90% or better. The remaining being self-directed or family-driven services. So just to sort of draw what that picture looks like for you, and we can, my staff will follow up and make sure you have the breakdown of services across service types from our management information report. I mention it a lot. It would be handy for those who continue to have interests in our community. We publish those reports in terms of transparency. We publish those reports quarterly. We're getting more timely with the publishing of those reports, and they are public facing, and you can find a lot of really useful data. And not necessarily data we're specifically proud of, the kind of stuff you're looking for. Where are the concerns? It's reflected right there, some of what goes on. And so we will make sure you have a link to that, so that when we're talking this summer and next fall and heading into next session, you don't have to rely necessarily on my staff producing you data, but you can have access to that data year round. And I use it all the time in prepping for meetings like this and in conversations with stakeholders in my open door brown bag luncheon type sessions that we do.
Thank you. And my second question involves, you noted that you have the business intelligence unit now and a data scientist that you've been working with. Are you saying that, and you mentioned all the data systems and how you're able to work between them, right? Are you saying that some these increases may also be attributed to you being proactive about looking for these problems or these cases? And is there a way to distinguish those, to pull those out and understand more about how you're being proactive and maybe, I don't know, just looking for solutions for where the gaps are, where the.
I'm going to reframe your question to Katie because I may not have the data with me today. Do you have the data today that says what we've pulled from PulseLight? So we can provide you the type of reports we get from our use of that electronic platform that was originally designed to look backwards and still does for combinations of injuries and incident reports and outcomes that would indicate there might have been abuse and neglect. How we use those reports, we have a whole system that funnels to someone at central office who then works with the regions to trigger additional reports based on things we found in the data that were never reported to us. That triggers at times additional investigations. I can get you what that data looks like, but I don't know it today, as I said before you.
So once you close a case, it's closed, or do you just keep them open, I guess I'm wondering how it works logistically if, there's no report and then you go to them and it's already been sort of finalized.
Yeah, thank you. So there are times where what we see in the data does not reflect. So we pull the data from the Medicaid Management Information System, the MMIS, and it suggests that the type of injury that occurred to someone's rotator cuff is because they were swung by the arm. That's what we can learn from the data. And the person who swung them by the arm didn't self-disclose and report that. And so we go back to the agency and we say, hey, there was a shoulder injury that's consistent with this. Was there any incident report that day? Was it qualified as a critical incident or just a minor incident? Was there an investigation as to how that injury occurred? Were there other things that happened during that time unrelated to abuse and neglect? Was there a fall at a day program? Were they participating in an athletic event? Had they been bowling? Like, what are all the things that might have contributed to an injury to a shoulder? So we use that PulseLight Aura data to point us in a direction that, and this is the work we did really closely with OIG. How do we use that data to look in places we hadn't considered looking before to see if there was potentially something that was unreported? We then may require the agency to report something then. We may require them to make a referral to OIG, to AID or DOI for an investigation to begin. Again, the Medicaid claims data sometimes is behind, and it's very hard to substantiate something that the staff involved may no longer work at the agency and they're not going to produce themselves for an investigation. But we can at least document that there was potentially abuse and neglect, and it would lead to something unsubstantiated potentially. And that may be one of the reasons those numbers are higher, is that the circumstances around what we're reporting aren't readily available because it's not timely because of the way we collect that data. But that is the work that the feds have asked us to do. And again, while folks aren't super excited about this number, the fact that we're doing it is, and it's being replicated across the country is an indicator to me that while we have a lot of work to do, in many ways, we're still a leader in this area, despite the concerns raised by the data we furnished to you.
It sounds very labor intensive, and thank you for that work. Thank you.
It has become a little more labor intensive, but we used to have a backlog of these, and we are now able to queue them up and dispense with them much more quickly than we used to. So we no longer work with a backlog, whereas we worked with a backlog for years on these things. The improvements in our ability to leverage data has just grown exponentially through the good work of my staff in that unit. And they are fascinating to engage with. They're really smart people, and I'm very glad to have them on my team. Even if it makes us look like we're performing worse, I'd rather be transparent about where we're failing than to not know these things occurred. And that's why the partnership with the feds has been so important.
Great, thank you. I have a few more questions and then want to be conscious that we do have additional guests. When it comes to the guardians of these individuals, if a provider reports an allegation to your department, who's responsible for reporting that to the guardian?
I don't want to speak incorrectly. Case management. The case manager would be the person who would report that to the family that an allegation has been filed. Certain providers will reach out directly to families and guardians as well. Sometimes families or guardians are part of the questions being asked and may not be included right at the beginning because they may be considered witnesses or perpetrators. And so they are alerted differently as they may be asked for statements. And we want the integrity of the investigation, if it can lead, particularly in egregious cases, to a judge issuing an order of a sentence or a crime having been committed. We want that investigation to have as much integrity as possible. But the responsibility from DDS's perspective is on our case managers.
Okay, thank you. And then it's my understanding, but please correct me if I'm wrong. So if an investigation is conducted by the police or state's attorneys, there will be communication between the investigators, the victims, the guardians, and legal counsel. What's been shared with me is that when the investigations between the provider and DDS, there is no communication permitted with the guardian. Now, if the guardian, and so let's take off the table a guardian that's involved. Totally understand that. But if it's been deemed that the guardian has no involvement, they are not the abuser in any way, is that policy? And why wouldn't they be included in that investigation?
It isn't policy to not include them.
Okay.
They sometimes bring no bearing to the outcome. They weren't a direct witness. They weren't on the scene. They weren't part of reporting. So they may not be interviewed because when you're looking at the investigation, they are neither an alleged perpetrator nor a witness. Where we have worked with one of my families in particular, and what we are talking about would be the ability to include an impact statement from guardians, not necessarily for the case being investigated, but so that families can bring to staff's attention and to the investigative process their belief in what the impact of these sort of adverse outcomes brings to bear on the individual in the moment and in their lifetime. I have not gotten to the point of understanding fully what I might make that look like, but we have talked about what an impact statement adjacent to or in the planning whether we have it adjacent to investigations or part of an intake and planning document or someplace else in our system. But that would be separate from their role in an investigation regardless.
Okay, thank you. This was brought up earlier, and so I wanted to dive a little bit deeper. So there's been a reduction in the substantiation rate. Even though we've seen increased in reports. Maybe I got it wrong. Earlier when you were talking, it seemed to be a positive thing based on the increase in reports which I do get this, that an increase in reports means there's more information available and more understanding about issues. And so we could see an increase in reports, especially since we're also post-COVID. Why, though, the reduction, do you think, in the rate of substantiated?
I think because of the training that we have done with staff, that it isn't that they need to know abuse and neglect occurred before they report, but that there may have been abuse and neglect that occurred that causes them to report. So we would rather, we train folks to err on the side of caution. And I would encourage, the agencies prefer over-reporting to under-reporting, the private sector agencies, as do we. We would rather folks over-report rather than under-report on these counts. And again, I'm making, I'm inferring from the data that that may be what's happening. I don't have any way to demonstrate a causal relationship between those two things. It's my gut instinct that that is the case, that we are reporting more. And maybe things that don't rise, that don't rise to the level of even being intakes, but they're being reported. And so we record the do not takes, DNTs. There's one of the data points before you, where allegations are reported to us and we don't even take the investigation because it doesn't meet the statutory, the accusation doesn't meet the statutory threshold of the definition of neglect or abuse. But staff are reporting it regardless because they've been trained to see something, say something.
Thank you. And then building off the data scientist role and the data that's out there that we could potentially use going forward, or maybe you already have this. Do you already analyze where the majority of the abuse and neglect allegations are occurring? Are there certain programs, agencies, homes? And I'm not saying, again, based on what you said earlier, that needs to become public knowledge per se, but do you know that, and are you tracking that?
So the current system can't be public facing because there's health protected information embedded throughout. It's direct claims information from the Medicaid management information system. It's the definition of a HIPAA violation, right? Health protected information. My quality managers who sit in the regions are able to look at that system, and it's so far beyond where we were 10 years ago that they can click on an individual and see them across settings. They can click on a group home on a map and drill down into that group home and see that specific group home and what its quality looks like. When Katie was talking earlier about information pulled together for quality reports, that Aura system gives us some really good data points on that, because not only is it capable, not only has it ingested MMIS to detect potentially unreported incidents, it has the whole catalog of reported incidents. It has the whole catalog of all that other information. So we can actually see person by person, home by home, town by town, if we wish to, and regionally, what that looks like. And we can share that with providers. It's also one of the tools we use to make decisions as to whether we place a provider on enhanced contract monitoring, or whether we raise to an agency, hey, our data shows 3 falls in 3 months. And for folks who are aging, multiple falls in a short period of time is a prime indicator of other impending health decline. So while it's not related to abuse and neglect, we can use that data to look forward and say, hey, we should probably be looking at things like Alzheimer's and dementia for this person. So it has a lot of really rich data. And while we are further along than a lot of people in leveraging MMIS data, we have a lot of growth there still to do because there's just so much data. And in fact, our data scientist just sent out what I call a Whitney. Wouldn't it be nice if asking staff, listen, we can produce more reports. What else would you think would be helpful? So nurses are asked, what would be helpful to know from the data that exists? Case managers are asked, what would be helpful to know from the data? Because she's not necessarily a lifer in our system, but she gets what she's doing. And so if people ask her the questions, she can ask the data. She can look at the data and provide those answers to them. And that we have lots of room to grow there, but we are strides and strides ahead of where we were initially at how we use that data. And we might be able to produce, with the company's help, a demonstration that would be de-identified that we could share with you in terms of the robustness of that data and how we use it. But the way our purview is not de-identified, it's completely identifiable information. But we could talk to the provider, so you could see why we continue to invest our time and talent and money with this company to help us do better.
Because I think it would also be important and interesting to look at the data in terms of which individuals with which types of disabilities maybe potentially experience abuse and neglect at a higher rate. Again, de-identified, but that could help with future training and where we need to build up staff.
Representative Gilchrist, that's a great point. And my families will tell you we use a level of need tool that sort of categorizes people by what their level of need is, and within that data, what drives that need, whether it's a medical issue, whether it's a behavioral issue, whether it's a communication issue, whether it's an ambulation issue, whether it's a safety issue. And we can definitely get at the data to categorize by level of need. It would take some work, but we could pivot data to look at our level of need based on allegation and things like that. It gets, when I talked earlier about incidents where there's 5 people under the same allegation of neglect, it gets a little harder to parse that apart because it would be considered 5 incidents. But we can look at that. We can look at how to produce data along those lines. And I think what the report we produced to you was responsive to the statutory requirement. The additional questions you're asking today, I don't think you need another statutory change. If there's specific data that you're looking for that we can legally share with you because of the HIPAA stuff, we are happy to work within our resources to produce additional reports and data. I want to thank Katie and our business intelligence unit for producing the report they did produce. And it is very specific to the statute. If there's other specifics you would like, you can just ask.
Wonderful. And thank you for being here, and I look forward to the continued work together.
Thank you.
Next, we will invite up Sarah Egan. Do you want to come together? Sarah Egan and Tom Cosper. Thanks so much. Thank you both for being here.
Good morning, and thank you for having us. I'm bringing up my computer because I told myself this morning, don't do what you always do and leave it on the printer. And then I left all of my wonderful documents on the printer. Hello, everyone. I'm Sarah Egan, and I'm the Executive Director of the Center for Children's Advocacy, which is a statewide legal rights organization for children and youth. Prior to that, I was the state child advocate for 11 years, and in both those roles have looked at quality and safety for highly vulnerable people dependent on publicly funded services for their survival, which is why we're so appreciative of this hearing today. I do have some things I want to go through. I thought it made sense maybe for Tom and I to come up together, and then we can answer any questions that you have. As a preliminary matter, I want to thank the committee. I want to thank my colleagues from the Department of Developmental Services, who I will say, I've done a lot in my career of looking under the hood and asking a lot of really nosy questions of local and state government. Those questions are not always appreciated. But I can say that my colleagues at DDS have always been very professional, very responsive. And you see it here today. I mean, they're an open book when you ask them, and there's no glossing the narrative. And I think that's really, really important because we can't wrestle with state agencies over where we are, or we're never going to get to where we need to be. So I do want to acknowledge that, and I do appreciate it. I also want to thank the families that have driven this advocacy, because these are the issues that they and their loved ones live and breathe every single day. And while I'm going to keep my professional hat squarely on today, I have shared with, members of the legislature that I am also the parent of a child with profound intellectual and developmental disabilities who will be dependent on this service system for the rest of her life. And like the other family members in this room, I live and breathe that every minute of the day, right? No matter where I am, that's just reality, right? And so I do want to, and Tom and I were talking about, what do we want to underscore here today? Like, what is the purpose of this hearing? What do we need to walk away with? And you've covered almost everything I was going to talk about. So, though I have a couple of things I wanted to highlight. I think what I want the committee to walk away with are some of the things you've already identified. One, and I say this with all due respect, because I can't mince my words with the things we're talking about and the people sitting behind me. In my opinion, this is not a safe system. There have been improvements made. There has been a good faith effort to address the concerns of families and federal and state auditors, but we are not at a place where I think one can reasonably conclude with confidence that throughout the state on a daily basis, a highly vulnerable population in a system that is still dramatically underfunded and dramatically under overseen is providing consistent, reliable, safe care to a population, many of whom are communication impaired, to report what is happening for them. That does not mean, when I say that, let me be clear, that I'm not saying there aren't great providers, there aren't amazing people who do heroic work for less than a living wage, because the fact that anybody does this work is miraculous. It's like the miracle of the human spirit, right? But that does not mean it is a reliable and safe system. And I think that's part of what you're reacting to today. Second, it will require the partnership, leadership, and oversight of this legislature to work with the agencies, both DDS and DSS, as the responsible Medicaid agency. That's there. They sign on the dotted line to the federal government that this system is safe. Those Medicaid assurances belong to the Medicaid agency. So it will take the leadership and partnership of the legislature and DSS and DDS and the advocates and families to continue chipping away at these enormous challenges, and a commitment to what it really takes to fund a system of care for highly vulnerable people, right? Because as Mickey Kramer, the longtime associate child advocate, used to say, if you don't support and you don't inspect what you expect from systems for vulnerable people, you get what you get. And that is not good enough, right? So I want to be really clear about that. Couple of other things I wanted to highlight. One, just in response to some of the questions, Representative Kitt, you asked this, a few of you asked this question about unsubstantiations. So it's the same in the DCF system. Substantiation is tied to the perpetrator. I think that's something we can fix, right? So if a child's in a group home or a school or wherever, and there's an unexplained injury and bruises on the ear or other problems, right? And the child doesn't talk or otherwise can't reliably report, and there's a report called in by somebody, grandma, nurse, whomever, and DCF investigates it. If they can't identify a perpetrator, that's an unsubstantiation, and nothing happens from it, right? So I think when you're talking about vulnerable populations, that's a concern. I did file a submission with the committee for today that I just wanted to walk through a little bit. You heard I said the part in blue right on top. So we talked about the data from the report. I agree with Commissioner Sheff that it is better to over-report. I don't know that I draw a conclusion based on the substantiation rate of 43% that abuse and neglect is underreported. Right? One does not necessarily, I would assume that abuse and neglect of vulnerable individuals is always underreported because you're dealing with a highly vulnerable population that many of whom are communication impaired in an underregulated system. So I do think it's important that those numbers go up. It is important that the substantiation rate go down, but I still conclude that it is underreported. And to Representative Gilchrist, your comment about who are the populations who are most at risk. Well, data tells us a lot about that. So the higher the level of need, generally the more at risk. National crime data tells us that people with intellectual disabilities are the victims, and this is just what's known and reported, are the victims of sexual abuse crimes at a rate 7 times that of the general population. Children with disabilities, youth with disabilities are much greater risk of abuse and neglect, and having that abuse and neglect not be reported or having that youth not be believed that abuse and neglect is occurring. So there was a lot of discussion today about what's in the report from DDS and what isn't, right? I think certainly the report is a starting place, right? And then there's a lot more information that may be joined by a lot more people. So There's a lot more information. I do include in my submission suggestions for eventual amendment of this reporting requirement. I think certainly nothing precludes the committees from asking for more information from the agencies, and certainly that was provided today. I do think at the end of the day, it is important that the statute reflect what the legislature needs to know. So I do want to highlight that the big questions are about how we detect, how we prevent, and how we respond to concerns of abuse or neglect. So I do want to put a big red circle around the acknowledgement from Commissioner Sheff and his team that one of the major weaknesses in the system is how we follow up, right? Because I have seen it in some cases I've looked at myself. We certainly see it in the data and in what Commissioner Schiff talked about today, that when you are doing these investigations and making these findings, whether they're done by the private provider or they're done by the agency, right? I think it was, I have the number in here somewhere, but thousands of corrective actions directed by the agency, with very little system in place right now to follow up and ensure that those are actually implemented in a timely way. Tackling that is going to be critical. And if we think about other agencies and state government, like if OEC, Office of Early Childhood, goes out to a childcare setting, and they have, first of all, they have the best publicly facing database in the state because they use 211 and e-license. So I can look up like Little Sarah's Daycare, and I can pull up the inspection history and the documents, and they're going to tell me what the regulatory citations were. And I'm going to see in the timeline that they're, anytime they find a problem, they're back out quickly, right? And by default in state law, they're going out yearly unannounced. That is not what happens in the DDS system. So I think there's two pieces that connect here that I think it's important for the committees to understand. One is the investigations process, but the other is the licensing process. Right. So you have your investigations, and none of, these documents are not public, as we've talked about, and you have your licensing framework where for the DDS system, some of the licensing documents are public, but e-license system is very clunky. You don't get a lot of the data there. You don't get any of the corrective actions there, and you don't get any of the documents about how the corrective action was overseen, like you would if you pulled up Sarah's Little Daycare on the 211 database. You get all of that, right? So that's what we should be building to ensure transparency and accountability. If I'm a parent and I have a child in a DDS licensed group home, and let's say my child is not the victim of a particular incident of abuse and neglect, but DDS or DDS's provider does an investigation that says, geez, we have some problems here, and issues not only findings about that perpetrator and victim, but also, as they often do, findings of programmatic neglect and a series of corrective actions. And I'm Tom's mom, and he's not the victim. I don't get any of that information. I don't know any of that necessarily, right? And so that's where this issue about who gets to know what, and transparency and accountability for those programmatic findings that DDS and its investigators or regulators make is so important. Just referring back to my submission, I wanted to highlight, you heard some of this today, that the context undergirding this report is a series of federal and state audits that have occurred over the last 10 years, making the same findings we're talking about and you're asking about today, right? It started with the Office of Inspector General for the U.S. Department of Health and Human Services in 2016, making findings, all the stuff you've heard about. How are we detecting? How are we reporting? How are we following up? Found very significant concerns, issued a number of corrective actions. They came back in 2023, did a re-audit, found good that DDS and DSS had implemented all of the corrective actions that the OIG had directed, but OIG found it didn't solve all the problems. And there were still unreported, undetected incidents of abuse and neglect, 75% of which detected through ED claims were for bodily injury. right? And the OIG attributed that to still developing data systems, but also staff shortages, right? These are where these two things go together all the time. The Office of the Child Advocate, and I was still the child advocate at the time we issued this report, in 2023 we did an investigation and report on a very serious critical incident that occurred involving two young people in a DDS licensed community provider agency, and kind of dug into all of that. The big thing I want to highlight from that report is, one, it was a very serious incident involving an ED visit, two young people, allegations of sexual assault, first responders making calls to the Office of the Child Advocate and the Office of the Victim Advocate. And yet months later, when I asked for all of what is everything that got investigated and everything that happened and everything you did to like make sure things were good in the group home after that, that file was like tissue paper thin. And I worked very closely with the commissioner's office, with Katie. They were terrific helping us follow up on that. But boy, did it raised very huge alarms about how were we following up on the care for these individuals in this group home? And it echoed almost word for word. And this is 2023, so this was 7 years after the OIG report, of how much had we really fixed, right? And then 2024, you have the auditors of public accounts, or 2025 or 24, I can't remember, issuing their report about delays in morbidity mortality reviews. And hearing today, it's so sobering that there are 15 deaths reported as, and I understand that system, let's overlook it, right? But that did result in, 10, if I heard Katie correctly, 10 findings of programmatic neglect. I mean, it's just staggering information, right? And I appreciate the transparency today from DDS in talking about that. So, it's these series of federal and state audits that continue to this day. And so I think the committee is correct that this is going to take year in, year out partnership, resources, oversight, leadership, commitment, the input from families to fix some of these things. The Center for Children's Advocacy is including a series of recommendations in our submission. You have them, but goes through all the things that we've talked about, amendments we can make to state law, amendments we can make to current bills. But we are here, we are in it with you. We are in it with the department and with these families to do the work. I think it's another 10 years worth of work. It is another 10 years of work to get us to where we need to be, but we're going to have to do it and hold ourselves accountable to that. So those are the comments I wanted to make.
Questions, or did you want to make any comments?
Sure, it's your
Okay, thank you. Thank you both so much. And yes, see what you've submitted, truly appreciate it. I'd love to, I see in your recommendations and in speaking with others, it's come up, the staff, so it's not all staff, and I do want to make that clear, but the perpetrators of the abuse and neglect. Can you maybe speak more? I know we have been talking a lot about underpayment, which I do believe is a huge issue. It's ridiculous, and we need to pay people, especially who do this important work. That said, are there things we know, or more likely, are there things we don't know about folks who perpetrate abuse and neglect against this population? And are there things we can be doing to prevent them from taking these jobs?
It's still on, right? Yeah, that's a really good question, Representative Gilchrist. I mean, number one, yes, people need to be paid a professional wage for doing a very hard job, taking care of high-need, vulnerable individuals in sometimes highly stressful situations. So I think that's one. Two, there's always an opportunity to look at the adequacy of credentials. Like, do we want to have standards for, what are the current standards for how care, for who we're hiring to deliver care. What does background checking really look like? That's a thinner system than people think it is, right? I'm saying that sort of across our agencies that serve vulnerable people. Background checking often consists solely of checking registries. I don't want to, get something granular about the DDS system wrong, but in my experience, these background checks are pretty high level. And it is not uncommon for people, and in fact, in the investigation that I did with the Office of the Child Advocate on these issues, that was in there too, that someone who had a troubling past somewhere else wound up being hired by this group home. So I think that's another area to look at, the adequacy of those checks. In a fatality review that I had done as the child advocate, where a child died and their foster parent was charged with drunk driving when they went to pick up the child from school. That foster parent had been a licensed foster parent for DDS. So just before that. So, so background checking, cross-agency checks is another area to look at. And then some of the other things that Commissioner Sheff and his team talked about, right? Are we invested in the training and support for staff? Staff need a lot of support to do this work. They need supervision. It's not the compensation, the benefits, but it's also the supervision, the training, the support to do work that doesn't come naturally for everyone. So how are we funding providers to do that work? I think is really important.
Yeah, thanks, Sarah. And yeah, I will keep my comments brief. So I will kind of, if that's okay, Representative Gilchrist. Again, Tom Kosker, Disability Rights Connecticut. Thank you guys for having us here today. We covered a lot of stuff today. So again, same thing as Sarah. A lot of my points I have outlined that I want to talk about have already been addressed. But again, we do at Disability Rights appreciate working closely with DDS. We work with them on a lot of things. In the past, not as much as we'd like to on this area, but we look forward to continuing to work with them and you all on this, on abuse neglect. As everyone said, the numbers are staggering. To me, 1 is a staggering number, right? Like if it's 1, it's too many, I think, and we all would agree with that. But we know it happens. We know these are vulnerable populations, vulnerable individuals. I've been saying this similar thing for a number of years now, right? The third party investigators is a huge issue, right? Providers investigating themselves. It's baffling. I understand why it happens. A lot of it's funding. I don't want to point to funding as an issue, but it is part of it, right? Commissioner Sheff addressed that, and I think it's a huge issue. I think the follow-up is a part where, we talk about a lot in special education as well, right? The follow-up of corrective actions, again, it's been addressed, but I wanted to just touch on it. And we ask them, have you made the corrections, right? And there's an attestation. They say, yes, we have. And then you go back and 6 months later, a year later, and more stuff happens. Then you go back 6 months later, and a year later, and more stuff happens. So how good is that system really working if that's the case? And DDS, they have the enhanced monitoring, which I think is helpful and works. But I think there's work that needs to be done on those systems. And also for an individual, right? An individual, we talk to clients all the time, right? We do our own investigations on allegations of abuse, neglect within the DDS system and broadly in other areas of the state. And I think of a particular client who not had 1, not had 2, not had 3, but upwards of 8 or 10 allegations, most of them substantiated inside of a year. It's hard not to cry. It's hard not to get emotional about that. That's really tough, right? For all of us in this room to have one of those happen to your child, to have multiple. And we worked very closely with DDS on this, but those are troubling things. So what in the system is a problem there? And we've talked again about a lot of those things today, but I just wanted to bring up that example. Like every one of those, whether it's 4,000 or 1,837 substantiated, is an individual, right? Whether it's 5 for one person or 6 or 8, or it's 1 per person, that's an individual that got abused or neglected. Understanding many of them are neglect, there's less that are abuse. I applaud the legislature for passing this law 7108 last year and creating this report. I think it's an important step. Again, they've been very great. The DDS has been great, Commissioner, on agreeing to provide additional information, additional questions, which is great. I think we should do that. We should continue to do that to answer the questions, give us the information we need. But at the same time, point that Sarah makes, sometimes it takes that you need to do it by law. And so I think there's some tweaks in the report that you've brought up as well, many of them, and I thank you for doing that. But around the settings these things are happening, the role of the perpetrator. Another issue that, I brought up in my testimony I provided was back on 5558, that bill, and it's similar to this. A lot of the points I put there in my testimony were discussed today, but is around in Commissioner Chef addressed this, I believe, in his testimony to that bill, is the receiving of the report by the parent or guardian, afterwards, of the abuse neglect, once the investigation is complete. And it's a tricky thing, right? And I understand those need to be looked through and redacted as needed. So there's a lot of aspects that make that difficult to provide, and parents can get that if they ask for it, and they can ask Commissioner Chef, at his office for a copy of that report. But that's not widely known. I'd love to see that happen every time. I understand there's limitations on doing that. There's resource limitations on getting every copy of every report investigation to the families. But to not get that is just baffling to me, right? Like, how do you, as a parent, as a guardian, go forward with knowing this investigation happening? You don't really, the result of it, substantiated or not. You don't know the recommendations. You don't know the follow through. And I'll wrap up because I'm sure I have a million things to say. But again, I appreciate you all. I appreciate DDS. We look forward to working with you. There are a lot of issues. DDS has acknowledged those issues. We need to work together on that. It's a matter of resources often. It's a matter of thinking these things through. Again, yeah, I'll leave it at that for now. Thank you.
Great. Thank you so much. Representative Dathan.
Thank you so much. And I appreciate your testimony and your thoughtful words that you've put behind this very important subject. One of the things that I think we could do is really improve our training. And that was something I didn't really understand, if that was something you felt that our state could do better to prevent some of these allegations in the first place.
Yeah, and Commissioner Chef addressed this as well a little bit, but it's very often, it's the most common recommendation through these investigations. I think if it's not the most, it's pretty highly the most. Training of staff. So yes, we encourage that. I think it's strange though, right, that if we continue to make that recommendation time after time, investigation after investigation, then what's going wrong? So I think we need to back that up and look at how can we be more proactive in this, right? And there's a lot of training that's done. Trust me. We talk to case managers, we talk to staff, like they're trained a lot on a lot of things, and there's a lot of things to be trained on. I have an 18-year-old son with a lot of needs. There's a lot to know just about my son to provide services to him and support him. So I know none of it's easy, but yes, I think that the training is a piece. Then is the training happening, and is it happening with fidelity, and is it being delivered in a way and then used in a way that is helpful for the individual, right? So we can check a box and say Tom was trained on this, and this, and we did the training, and some of it was online. And does that lead to improved outcomes for the individuals? Does that lead to a reduction in training? So we can a reduction in allegations of abuse and neglect. So if we can track some of that, like, and again, none of this is easy, but yes, training's super important. And Jordan addressed this as well. Reimbursing staff, agencies, providers for that training, right? They get reimbursed for direct care. If they're not being reimbursed for that, it's really difficult, right? So they're having to take it out of their pocket to do that training. So it's an issue that he addressed and is real. But
I fully agree. I think in order to have quality training and quality programming, you need to have that investment in training, and it really is an investment. And I think we as a legislature need to recognize that investment needs to happen for our neediest residents, our families, and so that we can prevent these things from happening in the future and any worse outcomes. So thank you so much, and thank you, Madam Chair.
Thank you. And Thank you both for being here and for your continued work on this for years and years. I hear you loud and clear when you say this is not the beginning, because I know so much work has been done, but this is a place and time that we now move forward. Again, so appreciative to the families who came and raised this issue with those of us in the legislature. This report raised more questions than answers, but has now set us off in a direction we can go to improve this system together. And so I'm looking forward to all of us doing that work together, and just appreciate everyone being here to have this candid conversation on this very, very important topic. So thank you so much, and we'll see you all soon. Thank you.
Thank you.